Hello everyone, thank you so much for joining us this evening. My name is Nathan Taylor and I have been a Bloomsbury Clinic patient since my HIV diagnosis in 2017, so I'm coming up for my 5th anniversary this year. I would like to extend a very warm welcome to everyone joining us this evening. This is an open webinar forum, so it is no inference can be made about anybody's HIV status just by the fact of their attendance here tonight. This is open to everybody, so there will be people who are living with HIV and people who are not as well. Being a webinar format rather than a Zoom meeting, only the panelists' videos will be seen by the people attending and watching the webinar. So anyone who's attending, your security is very, very important to us. So before we get round to kicking things off with Laura, our main guest tonight, I'd like to introduce you to Geoffrey Milton, who is the Bloomsbury Network Lead. Here he is, should be on screen with you now. And Geoffrey wants to talk about some very, very exciting things that are happening for us here as the committee members of the Bloomsbury Network, and things that we will then be able to pass on to you through the work that we do with you guys in mind. Geoffrey, over to you.
Great, thanks ever so much for the introduction there, Nathan. Hello everyone, yeah, my name's Geoffrey Milton. I'm the Bloomsbury Network Lead, and we've been working in the background with some partners to look at our funding from Camden and Islington commissioners, and I'm pleased to say that we've got 3 years more funding from this April to fund the services that we operate as the Bloomsbury Network. So that's really fantastic news. But the development that we've got going on there is we're going to be working under an umbrella organisation with Living Well, THT, Positively UK, Food Chain, and Living Well themselves. So this will give us an opportunity to work with other HIV service providers to provide more integrated and connected services across the work that we do. So that's really great news. There's going to be more information coming out about that. The other thing to say is that we have another BDC, Beyond Diagnosis course coming up on the 23rd of April, the 30th of April, the 7th of May. That's all on our website. There'll be some other dates taking place in June, and we're looking if we can to have that as a face-to-face event. And then we will be doing a forum next month all about the new way that we're going to be operating under the umbrella with Living Well. And then after that, we'll be running a CPAC session in June. Okay, over to you, Nathan.
Great, thank you very much for that, Geoffrey. That's really, really fantastic news. And for everybody listening, Geoffrey has been working incredibly hard and putting a lot of person hours into securing all of these. So from me, I'd like to say a great big thank you to you, Geoffrey. Geoffrey mentioned the BDC, as we're now calling it. It used to be called the Newly Diagnosed course. We're now calling it the Beyond Diagnosis course. And it's a 3-session course for anybody who may be having trouble coming to terms with their diagnosis. So, and we talk about lots of different things about living well and thriving with HIV today. There's information about the legal ramifications of living with HIV, discrimination, stigma, how we can build better lives as people living with HIV. For me, personally, it was absolutely transformative. Even if you have attended it before and you still have some questions, things, you'll be more than welcome to attend again, because obviously things change so fast in the world of HIV, which is something we're going to be talking about tonight, that we're constantly updating the content for the course and delivering it in ways that suit the facts as they are today. So if anybody is interested in attending the next BDC, do check out the Bloomsbury Network website, bloomsburynetwork.co.uk, and contact one of the peer support workers and let them know that you're interested, and they will sign you up on the list. It's a very private course, only for invited attendees, so it's not a forum like this. So it's a very safe space for people who may be feeling a little bit more vulnerable than a great big Zoom meeting might suggest and allow. So that's something that we're very proud to be able to offer, and it really, really is Very, very useful indeed. So on to tonight. May I please introduce our wonderful lead guest tonight, which is Laura Waters, who is the clinic lead, and she's also the chair of BHIVA, the British HIV Association. So if there's anything to be known about what's going on in current news in the field of HIV, Laura is your gal. Hello, Laura. Thank you so much for giving the time up to be with us tonight.
Nathan, and as always, it's an honour and a privilege to be here. Thank you very much for inviting me.
I deliberately didn't want to say what you're going to be talking about tonight, because I know you're covering quite a few topics. I just thought it's probably best to let you launch straight in and go for it.
Yeah, let's do it then. So, you've disabled my participant screen sharing, Nathan. Are you able to?
Let me see if I can do that. There you go. It should be now available for you.
So I think I need to share this screen and then do this, and hopefully now I can still see you, Nathan. So you should be able to see, well, hello on the slide.
That's exactly right.
Fabulous. So hello everyone, and hello, and there are my contact details. They'll be repeated at the end. So thank you for having me back. I've done a few of these, and I hopefully still do a few more before I retire at some point in the future. And this is a kind of a general update. And as I've discussed with Nathan, please interrupt us as we go along. And if I don't get through all the slides, I don't get through all the slides, and you can decide whether you want me back to finish them. So who is she? I thought I'd just introduce myself a bit, because many of you will not know me. So basically, I'm an HIV and sexual health doctor. So I went to medical school, did my general medicine, specialised in sexual health. And I kind of got my formal qualifications back in 2006. So that's when I could have become a consultant, but I decided to dabble in a bit of research. I worked on HIV trials at Chelsea and Westminster and Brighton, two big HIV and big HIV research units. And I've been a consultant at Mortimer since 2012. So it's my 10th anniversary this July. And it also coincides with being in the specialty for 20 years. I remember as a baby, a sort of sexual health and HIV doctor, listening to people who'd worked in HIV for 20 years and thinking, goodness me, that's a long time. But I am now officially have been working in HIV and sexual health for 2 decades as well. So the other things I do, and so one of the reasons I sort of have a reasonable, no one knows everything, far from it, but I've got a pretty good feel for what's going on, is as well as being a consultant, and I'm also HIV lead, as Nathan said, at the Mortimer Market, although we cover Surrey as well. So we have about 800 patients in Surrey. I'm officially HIV lead for Surrey, but the team down there really don't need me. They're quite amazing, as is the team in London. But I'm co-chair of the London Clinical Forum, and that's a network of all the clinics providing HIV care across London. And we meet up every 2 to 3 months, share ideas, share plans. And it's a really good way to sort of keep in touch and make sure that we're doing things well and sharing what works, but also what doesn't work with our colleagues. Chair of the British HIV Association, which I'm sure, as you know, is the national body representing primarily professionals working in HIV, but we also do an awful lot of work with the community. And our main focus, you won't be surprised, over the last couple of years has been COVID. So we've been writing guidelines for healthcare providers, but also information for patients, because it's settled dramatically, but at the beginning there was quite a lot of confusing and conflicting advice about COVID and COVID vaccines. As part of that role, I also sit on something called the Clinical Reference Group, or CRG, and this is a kind of national group who give advice to NHS England. So there's community representatives from different parts of England, and we give NHS England advice about HIV care. So I've got a reasonable grasp of what's going on related to healthcare in general, and of course specifically HIV. So this is what I'm planning to cover this evening. So I'm going to give you some sort of summary of what we've been doing in the clinic, and more importantly, what our future plans are. Touch briefly on COVID, some new developments in HIV treatment, and then just a couple of closing thoughts to share with you at the end. But as I say, please do interrupt as we go along. So starting off with the clinic. So I think not just HIV care, and certainly not just our service, the COVID pandemic meant we had to make, across all of society, but certainly all of medicine, very rapid changes. And we will not understand the harms of COVID for many, many years, not just COVID itself, but the harms that all of that interruption in the usual treatment and prevention services had. Now, one thing that is good is certainly on a global level, HIV care was much less affected than people feared initially. So lots of concerns about interrupted treatment, people not being able to get to clinic. And actually there were some interruptions at the beginning, thankfully not very much in the UK. But globally, the services really rallied and were able to keep most people on treatment very well, so that the harms in terms of interrupting HIV care, much less than were feared. There were big interruptions in HIV prevention and testing, and that may yet have a big impact at a global level. From a sort of more local perspective, we pretty much overnight had to completely change how we were delivering services, and doing that in a way that kept everyone safe, kept people as informed as we were able to, was really difficult. And of course, as you'll know, we just weren't able to undertake the usual engagement that we would. If we were making major service changes, usually we would involve all of you. So I guess it's to acknowledge that, to apologise if you ever felt that you weren't being communicated with, but ultimately we had to make some pretty difficult decisions very quickly. Now, clearly a main part of that was we couldn't bring people to clinic, and also people didn't want to come to clinic because we're in the middle of a lockdown, and there was a lot of anxiety for people with conditions that affect their immune system, including HIV, a lot of anxiety about exposure to COVID and risk of getting sick. So we shifted pretty much everything to mainly phone. We've always had an email clinic option, it's never been very popular. And then video calling, so Attend Anywhere is one of the platforms, owned by a private company, of course, that the NHS embraced. We have used that for some of our services. We haven't used it much for more sort of routine HIV care, and we're still, as many of you will know, primarily relying on telephone appointments. Now, to be fair, this was already an existing direction of travel across medicine. We've had a number of pilots to try and promote email and telephone clinics in our service, and they've always been pretty unpopular. We've never really managed to get much more than 5 or 10% of people on them. So COVID has accelerated a sort of direction we were already moving in. Now, where we're going to sit coming out of this is really difficult to say, because at the moment, I'd say at the peak, we were about 5% or less face-to-face appointments, because we made sure there was always some face-to-face capacity for people who really needed it, but at least 95% of the appointments were by phone. That's slowly been shifting, so we've opened up more and more face-to-face clinics, but we're at a bit of an impasse at the moment because the social distancing requirements in the NHS are stricter than in sort of general population circumstances. And at the moment, we can't really open up much more face-to-face and still keep people appropriately distant. So we will increase face-to-face, but I think it's fair to say we will definitely have more care by phone or email or video in the future than we did before COVID. Now, one of the things that we've been really trying hard to do is make sure information is accessible. So at a local level, we've relied very much on the website. So if you haven't looked at the CNWL Bloomsbury Clinic website, please do. There's quite a lot of helpful information. It had been updated to a point where it was actually a bit nonsensical, but thank you very much to members of the Bloomsbury Network, that's been amended. So it's not perfect, but as far as NHS websites go, it's not bad. You may well have received text messages throughout all of this, so we recognise that not everybody uses the website. So we know most people have a mobile phone because they receive their appointment reminders by mobile phone. So we sent out messages to everybody to make sure they were aware of the latest advice for people with HIV related to vaccines, for example. One of the first things we did, my colleague Al Teague, who I'm sure many of you know, went to Carphone Warehouse or somewhere like that and bought a really cheap old Nokia mobile phone, and within 2 days of COVID starting or impacting how we delivered care, that mobile number was on the website and people were able to phone directly through to speak to a doctor. And we thought that was so important because we know it's not always easy to get through. I know choosing option 1 of 6 is really frustrating. So by having that option, and we used to deal with an awful lot of calls. The volume has decreased, but we still have that in place now because it's actually quite a helpful way, and that number remains on the website if you're really stuck. And as many of you will thank you very much have participated in, we've had a patient survey looking at people's feelings and experiences throughout COVID. That's been repeated, and we're going to use those survey results along with some other things I'll tell you about to make sure that as we come out of this, we make the services even better in line with what you want and you need. Regional level, we did a lot of work across London, speaking to each other, sharing policies, sharing access, so making it clear to other clinics that if they weren't able to provide emergency prescriptions, we could. It was a real kind of bringing together and working together as much as we could. And then at national level, British HIV Association did a lot of work. There's countless COVID guidelines now. We work with community groups, we work with other medical organisations, we organised some research, and we made sure, after some initial missteps, I think it's fair to say, we made sure that we were included in some of the sort of national Department of Health and vaccine meetings to make sure that we were representing people living with HIV. And that was almost always me as chair, but also Josh, who's our community representative and media officer. So we always had like a two-pronged clinical and community BHIVA representation at all these meetings. And we did all right. So by and large, everyone got maintained on treatment. I can't say that post-Brexit, we've been able to post medications abroad as easily as we could at the beginning. But we were giving people longer supplies. We did a lot more home delivery, and we use an awful lot of Royal Mail, actually. That's now been replaced by the official companies who do it. But the main thing was trying to get everyone to keep calm, because a natural reaction when something like this happens is to want to make sure you've got enough medication. But we managed to keep things under control. There are a couple of slightly dodgy weeks when meds were getting quite low in supply across the country. But actually, by and large, people being sensible and us communicating clearly, most people in the UK stayed on their treatment as usual. And the other thing that's changed, of course, is, and this is difficult, I think, because many of you will be used to having particular blood tests at a particular interval. You know, when we first started doing fewer CD4 counts, as we learned that not everybody needs a CD4 count at every visit. And once your CD4 count is good, as long as you're undetectable, it doesn't need to be measured again. And that can take time for people to get used to. And so for us to suddenly turn around and say, actually, we don't need to check your kidneys, don't worry about it. You know, we say you must come in for your viral load. Apart from this time during COVID, it doesn't matter so much. And I think that's because we probably, a lot of the tests we do them out of habit more than necessity, but getting the evidence to prove that is really hard. So as we come out of this, so for example, we've got our national BHIVA conference next week, and a lot of people have looked at their local databases and looked at what's happened by doing less frequent monitoring. And as we evolve, we'll get more sensible guidelines, and there will be people who only need blood tests once a year. There are some tests we do that we probably don't need to be doing anymore, but we were able to make sure that people who really needed blood tests, and that includes if you really want them, we were able to still offer that. Assessing things like mood and anxiety and depression are common. They're even more common in people with HIV, and they're even more common during things like a COVID pandemic. And so being able to ask about that in a phone consultation can be a bit tricky, because when you're seeing someone face to face, there's all the other ways of communicating, you know, someone's body posture, their eye contact, and all those kind of things. So we try to make sure that we asked about mood symptoms at each visit, but we also made sure that we had things like check-in and chat. So some of our staff were also vulnerable and weren't able to come into work, so they worked from home and were phoning people in our check-in and chat service just to touch in and touch base and see how they were doing. And the other thing that we know affects many people, and again disproportionately affects people living with HIV, is domestic violence. And again, in a real life setting, there can be ways to pick that up. So what we did, and again, many of you experienced this, we've been asking about domestic violence at every single phone visit to make sure that it becomes just a routine question. And equally, we recognise that if someone's at home on the phone and the person who is the perpetrator of the domestic violence is at home with them, that can be really tricky. But by asking about it regularly, And almost every time people say, no, I'm fine, but it's a question I found a bit difficult to phrase. It's a new part of the conversation. And the number of times people have said, but thank you for asking, was really heartening, actually. No, everything's fine for me, but thank you for asking. But it's certainly become a sort of more routine part of what we're asking in phone consultations. And then when we think about virtual care, I won't go into too much detail here, but it's not right for everybody, and not everybody has access to a private space, to a phone. They don't necessarily have the data to be able to check in the website and this, that, and the other. And I think when it comes to language, using either a telephone or a real life translator outside a face-to-face appointment is really difficult. From a kind of individual level, there's times when we need to do a physical examination, have a listen to your chest and things like that. Sometimes people need multidisciplinary team input. So they might need to see me, but also have a chat to the pharmacist and have a chat to one of the health advisors, and most importantly, one of the peer support workers. And again, that's the kind of thing that's generally a bit easier to do in real life. The other thing is what we call opportunistic activities. So this is like, hello, how are you? Here's your medication. Oh, by the way, you need this vaccine. Or by the way, have you seen this latest trial we're recruiting to? And so what we need to make sure we're doing, and one of the things we're looking at in some focus groups I'll tell you about in a moment, is making sure we maximize opportunities. So if say you're having a phone call with a doctor instead of seeing them face to face, doing a bit more at your blood appointment, having some of the conversations when you pop in for those routine tests, or when you pop to pharmacy to collect meds. So we're making, it's this concept of making every contact count. And so rather than leaving everything to your appointment with your doctor or your specialist nurse, other members of the team will be asking some of these questions. But most importantly is honouring preference. And we recognise that not everybody wants to have their care outside of the clinic. Equally, some people really don't want to come into clinic unless they absolutely have to. And there's been quite a lot of debate about, do we need to say that people must be seen by a doctor face to face at least once a year, or at least every 2 years? And I think that's a difficult thing to measure and decide. And I don't think there should be any rules, because I think it's a decision that you need to make jointly with the person who's providing you.
For some people, that a decision like that actually might be a barrier to continued care if you are putting those kind of strictures in place. And who might be in a very vulnerable position and can't risk anybody finding out about their status. And even now, there are so many people who are still suffering from those kind of circumstances. Have you found, my question is, I suppose, have you found that there are people who have rekindled their access to care because of the virtual nature? Because we're in the Bloomsbury Network, we found that it does suit some people much more than face-to-face. It's not by any means everybody, but some people we've been able to connect with more clearly.
Yeah, no, absolutely. So we've got a number of examples of people who have re-engaged. And what's interesting, I think partly it's because of the flexibility, so they no longer have to come to the clinic. There's also, certainly at the beginning, I think a degree that we were all petrified when COVID kicked off. And I think many of us are still have a constant level of anxiety now, of course. And I think for some people, it was like any healthcare event. It's the same if somebody, let's say someone has a heart attack who's not been engaged with their blood pressure treatment or their HIV care. It's a trigger to sort of re-engage with your health. So I think some of it was driven by that. And there's actually some work across London presented at one of the conferences showing that there were people who re-engaged with care for the first time, in some cases in many years, during the COVID period. And there's actually some data from the US that was presented a couple of months ago showing that the proportion of people in their clinic with an undetectable viral load went up during COVID. Because again, it broadened the opportunities for people to have that conversation, have that consultation. And so there may be some things where it's actually better for some people.
So the good thing is we've got options now that we may not have had before. So hopefully to be able to reach and engage with more people.
No, exactly. So silver linings, I think we've touched on a couple. So we mentioned that US study, and I think broadly when we think about the barriers, so Nathan, you talked about people who for perhaps privacy or confidentiality reasons don't necessarily want to come to a clinic. Then there's in the practicalities. So when we think about people who've got caring commitments, who've got children, who've got jobs with hours where it's just really difficult to get into clinic, all of those can be made easier with virtual care, and by minimising the necessity for face-to-face contact, hopefully we're making things a bit more flexible. And what I'm hoping is a lot of what we've learned in routine care will translate to some of the trials that we run as well, because I think one of the biggest limiting factors for trials, comparing new HIV drugs with old drugs or whatever, is the time commitment. And I think being able to do as much as we can virtually, and within 5 years' time, every single test we do in clinic we'll be able to do by post. So people won't even need to come to clinic for their blood tests at some point. And already, as many of you will have experienced, we can do sexual health testing almost exclusively with home testing now. So I think things like kidney tests and liver tests are just a few tweaks behind. So these are the next steps. So we've been holding these whole team meetings because I think it's been really hard for the staff as well. We are of secondary importance, of course, but it's been really difficult not seeing people. We actually had a small face-to-face meeting today in our old meeting room that's become a kind of dumping ground for old chairs and desks that we managed to battle our way through. And actually seeing people again, it's incredible. So we're running these staff focus groups. So what we've done is we've gone through the national standards of what we should be providing. We've broken it all down, and we've got groups that include everyone from doctors and nurses and pharmacists through to the receptionists and the secretaries to try and get views from the whole team. Of course, our peer support workers are involved as well, and they're looking at different elements like what could we be doing better when you're having your bloods taken. What could we be doing better about making sure your flow through the clinic is as efficient and useful to you as possible. We're repeating, sorry, that's not the staff survey, that's the service user survey. So that's been repeated. Again, many of you have received that link. And then once we've got some ideas from the staff focus groups, we'll be holding some more service user focus groups. This is my plea to all of you, that please get involved, because we really want to share some of our ideas and our plans with you, because you're experiencing this and we're not going to make any changes without your engagement. And I guess it's just to say to all of you, we're not going to always get it right. We know we don't always get it right, but we will always listen and we will always change. But you just need to tell us what you need, what we're not getting right, and we will do everything we can to rectify it. But I think what was heartening for me is talking at various meetings. Again, we didn't get it perfectly right during COVID, of course we didn't, but I do think we did an above average job. I really do. And when I talked to some of the other clinics and the fact that they're not even allowed to update their own websites, that they weren't able to do X, Y, and Z, I think we did manage to achieve a lot. And I think the care wasn't perfect, but the most important thing is it was safe. And then we'll move towards perfect as we come out of this hideous pandemic. So we do need your help. And so again, this is a plea. I mean, you're here, you're engaged. Please get involved. Everyone's opinion matters. But I think it's also about asking you what can we do, and that's the clinic, but also the Bloomsbury Network. What can we do to involve the people who aren't here? This is where you can play a role, whether that's chatting to people in the waiting area, encouraging people who perhaps don't feel confident to come to meetings like these. Just help us to make sure that we're getting views from as representative a group of our clinic as we possibly can. And not everyone wants to, and that's okay as well, of course. But people who don't want to is fine. It's the people who do want to and either can't or don't feel comfortable to. Those are the people we really need your help in accessing.
It's about, as you say, it's not just, if people are perfectly happy taking a quiet sideline view, then that's brilliant and all power to them. But we just want to make sure we're not missing anybody out who feels silenced or who feels that they can't contribute. I've just seen a hand go up in our attendees. So this is probably going to be a really, really good opportunity for me to mention the Q&A. So everybody who's attending should probably have somewhere near the bottom of their screen something that says Q&A, or if you're on a touchscreen device, if you tap the screen, hopefully you have a Q&A option option there, and you can post your questions to us and to Laura in that, and we'll get round to answering the questions either as we go along or we'll filter them out until later on. So if you don't mind, the person who's just put your hand up, rather than mention you here or bring your voice into the webinar, which I do have the power to do but won't do, it would be great if you could pop your question to Laura in the Q&A, and we'll get round to that as soon as we can. And to everybody else, Q&A is there for you as well. Thank you.
Awesome. So moving on, COVID. I'm not going to dwell on this for too long. So there's three things to think about. Firstly is outcomes. So do people with HIV get more complications from COVID than people without HIV? And the answer is yes, a bit. So there's been lots of studies looking at this. And in general, people with HIV who get COVID are at a slightly higher risk of getting sick with COVID. That's being admitted to hospital or needing ventilation or ultimately dying, because of course that's the worst possible outcome. And people with HIV don't do quite as well as people without, but it's not everybody with HIV. And actually, if you look at some of the studies, if you don't have other risk factors for worse COVID, and that's being older, sadly something none of us can control, or having other conditions like high blood pressure and stuff like that, if you've got no other medical issues, then actually your risk of getting sick from COVID is the same as anyone else's. So that's actually quite reassuring. But it does, sorry Nathan.
I was going to say, that's one thing that comes up again and again and again. I've had so many people say to me, oh, I'm so worried about you with COVID because of your HIV status. And I've sort of blithely, I think, been saying, I'm not in an at-risk category within the cohort of people living with HIV, although we've all been given that sort of high-risk status, which I think is to our benefit in many, many respects. But it doesn't necessarily mean that just because I have HIV, I'm automatically going to be in those cohorts of most at risk. Would that be fair?
No, you're absolutely right. And I think when we think about people at super high risk, so somebody who had, say, a bone marrow transplant 6 months ago, or is on very strong drugs to stop rejecting a kidney transplant, they're going to be at much, much higher risk. Now, people who are newly diagnosed with HIV that's very advanced, or people who aren't on treatment and have got a high viral load or very low CD4 count, the immune system isn't working very well then. We know that, but for most people with HIV, that isn't the case. And so I agree with you, Nathan. I think if anything, we're slightly over treating some people with HIV. And that's taken a while to learn that. But I think by including all people with HIV in some of the risk groups, it's to make sure we capture everybody. And I think because the risks of vaccines are so very tiny, and the benefits of treatment, if you're offered it, still outweigh the risks, even if you're quite low risk of getting sick, then it's a sensible strategy to take.
Thank you. I like to tell people, I may have HIV, but I don't have a compromised immune system.
And that's absolutely right. And in fact, that we're just drafting, because I'll touch in a second on the new vaccine stuff that I'm sure you'll have seen in the news, that the spring booster is on our doorsteps. In fact, you can book them now, and that includes people with HIV. But the latest update from BHIVA, which will be out soon, does say that most people with HIV are not considered to have a suppressed or damaged immune system. So that's a spot on explanation. Then we've also got, why is this not moving? Here we go, vaccines. So the most important thing is vaccines work well. And even if you look at people who've got less effective immune systems, the vaccines still work well. Some people with very, very damaged immune systems don't respond to vaccines, but then they need repeat boosting doses. But people with HIV do respond to the vaccines well, especially after the second dose. Where there's a difference, it's mainly been shown just after the first dose. So we recommend everyone gets vaccinated. Some people need that extra dose. So for most of us, it was 2 doses as a kind of initial course. But for some people with a low CD4 count, for example, it was 3. Everyone's been offered a booster. So that means most people have had 3 doses, some have had 4. And now there's a spring booster campaign, which means everyone should have had 4, and some will have had 5. Now, a lot of people who've had 4 already didn't need for, to be honest, because they kind of over captured people. But again, we still recommend getting the booster done, because across the board, even if you've had COVID already and you've had your other COVID vaccines, each booster still provides benefit. And of course, they look at that data all the time. No one's got the time or the money to be giving vaccines where we really don't need to. And at the point where the vaccines aren't still evidence of benefit, then they will stop giving them, or they'll give them less often. But at the moment, if you've not been vaccinated, please do, or have a chat to us so we can talk you through it. And if your last vaccine was 6 months ago, you need your spring booster.
Is it also the case, and or is it already the case, that like with the flu jabs, which get tweaked every year to match the different strains, is that already happening with COVID vaccination jabs? Are they being updated?
So as you know, as the new strains of SARS-CoV-2, the virus that causes COVID, emerge, and then certain vaccines are shown to be less effective, they are constantly revising and reforming the vaccines. It's probably not going to be like flu, where there's so much variation and so many different types that you always need a cocktail of 3 or 4 different types in the flu vaccine. It will just be, each time you have a booster, it'll have been adjusted slightly to match the sort of more common variants. But I think the key thing is, even if the vaccines aren't as effective, so, you know, the vaccine might work really well against strain A, but less well against strain B, even in that case, they're still highly effective at stopping you getting really sick. So even if they're not stopping you getting COVID, they're stopping you getting sick, regardless of what type of COVID you have.
That's the most important thing. There's so much fake news and misinformation about vaccines out there. I read something disgraceful week on a website which was saying that the government has just leaked information that the vaccines are causing the general population to catch AIDS. And of course, it's just absolute nonsense. But with all of those things, one of the biggest misconceptions that I've come across is that people say, well, they obviously don't work. I know people who are still getting COVID, but that's not what the vaccines are there for. They're there to prevent severe illness, hospitalization, and death. And from everything I've read, they do that very successfully.
No, that's absolutely right. And then the third thing just to touch on is treatment. So people with HIV, so everyone with HIV is eligible for something called the panoramic trial. So we recommend you have a test at home. If you get symptoms, you do a test. And if it confirms that you've got COVID, you can go online. It's all on the British HIV Association website. And it's also on our clinic website, panoramic trial. Anyone with HIV, regardless of age or other conditions, can do this study, and you'll either get a COVID treatment or you won't. But actually, many people with HIV are eligible for COVID treatment on the NHS. So if you're over 55, if you are obese, or if you have another condition like kidney disease, you will be offered treatment. So many of you will have had letters already from the NHS saying that you should have a test at home, and you will be contacted by the NHS. And then someone from a COVID medicine delivery unit will phone you and talk to you about the options. And this, Nathan, is I think where you have some story to tell.
Yes, I am a week away from last week. I had COVID, so my quick background is that I was one of the OG COVID strain sufferers. I was ill with the original strain of COVID a week before the first lockdown. I was ill for about 2.5 weeks, and I was quite seriously ill. Only my HIV seroconversion illness has ever been worse. So I was pretty poorly. I've had my 3 jabs, my 2 main ones, and my booster jab. I think my booster was in November. And then a week ago Sunday, I tested positive for COVID. I had a bit of a scratchy throat on the Saturday, did an LFT, lateral flow test, and it came back negative. On the Sunday, I was feeling quite rough, and it came back positive. The most important thing about testing positive with your lateral flow test is you must report it via the NHS and government website using your NHS login. If you don't have one, do sign up, because that automatically connects you with the team that Laura was just mentioning. And within 48 hours of reporting my positive test, not only had I had people contact me via email and by telephone and by text, they asked me questions about my general state of health. Otherwise, what symptoms did I have? and more importantly, what medication I was on and what reason put me in the high-risk category, in my case, HIV, and I told them the drugs that I take for that. And then they go away and they have a little conflab about me, and then they came back and they said, right, we think you're eligible for this type of treatment. And I didn't have the antiviral tablets. I was invited into the Watford General Hospital, and I was given an intravenous infusion, a drip of the sotrovimab drug, which is human neutralizing monoclonal antibodies, I happen to remember, which is the stuff that was taken from convalescent patients early on. Do you remember all these stories going out in the news that people who had already recovered from COVID had these antibodies within them, and so these were taken out and synthesized and tweaked, and they're now a drug which is there to help people stop getting seriously ill. I can't say whether or not it's just the drugs that I took, but my first positive test was on Sunday. By Thursday evening, I was testing negative again. And so although I got ill quite quickly, it was over very quickly, and the turnaround and the recovery time was incredibly short. So if anybody is worried about this kind of thing, it was so easy. It all happened automatically. I was in the hospital for about an hour and a half, about half an hour for it going into my arm, and then they just did some monitoring on my blood pressure and heart rate and oxygen levels, just to make sure that there wasn't going to be a reaction. They looked after me brilliantly well and sent me on my way, and I was well within a few days. So if anyone does feel that that's something that they would like, then make sure you say yes, but they won't be able to contact you if you don't report that positive test with the NHS.
No, it's just such an important message, Nathan. And when it also, so in classic NHS kind of style, when they first started rolling the COVID treatment out, it was on the 16th of December, perfect time of year to roll out brand new treatments in a brand new way. And as you can imagine, it was difficult finding the staff. So actually I volunteered. And so I spent a few hours on Christmas Day and Boxing Day, for example, phoning people through, because University College Hospital, the hospital we're very closely aligned with, who provide our pharmacy and blood test services and all those things. My cat in the background now, shush. There's two things I'll just share. One is I was expecting people to go, bugger off, it's Christmas Day, I don't want to talk about COVID. People were so grateful to receive a call because they were expecting one, because they'd had a letter. The other thing that's really interesting, I was speaking to people who had breast cancer, who had various strong drugs for various conditions. And when I said, why are you on the list? And they'd say straight away. And not everyone, but quite a few of the people with HIV I spoke to, there would be a pause. And for me, who lives and breathes HIV, talks about HIV, not just at work, a lot of time at home as well, I think it was a real reminder. And I know, of course, there's a lot of stigma, and I know there's a lot of fear, but it was just so striking that all of these other people with immune conditions were happy just to reel them off. And for a noticeable proportion of the people with HIV, there was that initial reluctance. And so what I started doing is when I phone people up, I'm saying, you have got a condition affecting your immune system, that's why I'm phoning you. I don't know what it is it HIV, is it chemotherapy, is it, and I just put HIV in that list of everything else, just to make people feel a bit more comfortable. But it was a real reminder to me that you know, how it is different for people with HIV still. So I thought that was interesting. So my next bit is just to update you on a couple of new new HIV treatments. So were there some questions in the chat about COVID?
Couple. One person saying, I have COVID at the moment. I was reading an article today implying that people with Omicron BA1 would probably be more at risk of catching BA2. Is this correct?
No idea. I will look into it. Yeah, I really do not know. I'd have thought if you had one particular type, presumably BA2 is very similar to BA1, that you might be at slightly lower risk, but I don't know. But I'll look into that.
The other one related to COVID before we move on, and we will get around to the others at the end, is if doing too many vaccine shots might be detrimental to our immune system. Is there a possibility that recalling the same vaccine too many times can compromise or bring the immune system to come to some sort of override? And is that ever likely to be an issue?
No, I mean, but almost certainly no. So it's just, when you have repeated vaccines, it's just another little reminder so your immune response is already there. And there's no evidence that repeating the same reminder is going to eventually overload the immune system. So the answer to that is no, you don't need to worry about that.
Would a good analogy be it's like taking your immune system to the gym? The more you work it out, the stronger it gets.
That's absolutely correct. And the thing is, the reason we don't give vaccines every month is, one, it's not necessary because the immune system stays, or the immune response stays strong enough. But also that's just crazy and would cost far too much money as well as the other things. So that's what we're going to learn as we come out of this, is how often do we need to remind the immune system. But when we think about flu, although the flu vaccine's adjusted each year, there's often a lot of overlap to last year's, and there's no evidence that repeating that reminder. Hepatitis B is a good example. And we probably give more hepatitis B boosters than we need to. Again, there's no evidence that repeated reminders about hepatitis B is going to cause your immune system any harm.
Now the really exciting stuff. I can see your number 3.
Yes. Well, let's see. HIV treatment. So the first thing I want to say, because most of you don't see me in clinic, I'm getting lazy as I get older. So you have to hear my 2 versus 3 drugs chat. So I know that we have been giving people mainly 3 drugs since the mid-1990s, and the reason that is, this is building on its own. So if we give you just 1 drug, the virus can basically jump over. It's not a high enough barrier to stop the virus overcoming it. And generally, with the older drugs, 2 drugs wasn't quite enough either. So you needed 3 drugs to create a high enough barrier to stop the virus jumping over and developing resistance. Now, some of the newer drugs are so strong that they're kind of like 2 drugs in terms of their barrier. So you only need 1 extra drug to create the same overall barrier to stop the virus overcoming it. So this is important because actually giving 2 drugs instead of 3, and I won't go to the main one's dolutegravir, I'll come on to that in a minute. Giving 2 drugs instead of 3 means you're exposed to less drug over time, which is probably a good thing. There's no strong evidence that it's necessarily safer than 3, but there's also no evidence that it's causing any harm. Sorry, they're jumping on without me pressing anything. But I don't like walls and I don't like barriers. So my preferred analogy is this, right? So if you've got a singer with a weak voice, they need 2 backing singers. But if you've got a singer, not bragging, but I'm pretty good at karaoke. If you've got a singer with a strong voice, you only need 1 backing singer. And this is actually, I've used this quite a lot in clinic, and it's an analogy that people tend to quite like. So if you are offered 2 drugs, do not worry. It doesn't mean it's not going to work, and it means that the team will have thought about, because we do make sure we review things like whether you've got any resistance to medication and stuff like that. So if someone does discuss 2 drugs with you, please rest assured that it's a good strategy. And we talk about 2 drug combinations or regimens. Really, the magic combination is dolutegravir and lamivudine, 2 drugs. Lamivudine has been around since the 1990s. Dolutegravir we've been using for quite a few years. They come in a single pill called Dovato, and there's something quite magical about that combination. So for many people, a 2 drug combination is just as good as 3. And if you're having side effects or problems with some of the other drugs, this is a way of reducing the drug exposure. So that's not particularly new, but I still think it's something some people feel a bit anxious about. So I wanted to mention it.
There's also just 1 tablet as well, and both of those drugs combined into 1 pill.
Combined into a single pill, yeah, it's pretty popular in our service. Now, the main thing I want to talk to you about is injectables. So I thought I'd just open up, and I don't think we have a kind of everyone raising their hands, but something for you to think about is, are you interested in injectable HIV treatment? And I would imagine that many people, of course, are. And there's many reasons for that. And I think the concept of not having the daily reminder of HIV by taking pills every day, or for some people, if they live in accommodation with strangers or family who aren't aware of their HIV status, all of there's many reasons. Some people don't like swallowing pills, they can't swallow pills. It opens things up, but it's not.
For anyone who's hearing about injectables for the first time now, can you just give us a little rundown as to what this means? So I know that the FDA in America have just approved cabotegravir and rilpivirine, haven't they? The Cabenuva combination. And that is also happening over here and is going to be rolled out very, very soon. And these are longer lasting. So obviously the tablets that we take have to be taken every day, but the big benefit that you're talking about is the fact that these can be taken once a month, or in some cases once every 2 months.
Absolutely. So and I'll come on to that, but so in Europe, which geographically still includes us, of course, if not politically, we're only going to have access to dosing every 2 months. So initially it was every month, got approved in the US first, approved monthly dosing. Europe approval is often a bit further behind, and they've approved 1 and 2 monthly, but the pharma company is only letting us use 2 monthly. I'll touch on some of the potential consequences of that in a moment, but yeah, it's every 2 months. And it means coming into the clinic every 2 months. We will be looking at getting this delivered in the community, either as a clinic or across London. I think it's fair to say that the pharma company, ViiV, who make this injectable, perhaps suggested they'd be offering a bit more support than they actually are. So I think there at some point have been hopes that they might use a kind of community nursing agency to deliver injections in people's homes, because, you know, I'm sure, as you can imagine, it's not something the NHS can magic up overnight. So it does mean coming to the clinic. It does mean coming in every 2 months. And the important thing is this is a deep muscle injection. So unlike sort of the injections that we give in the back of the bum, so if you've ever had a contraception injection, or you've had syphilis or gonorrhea treatment, for example, it's kind of in the back. This is at the side. So you can see from this diagram that is kind of just over the hip bone. It's called a ventrogluteal injection. It's actually meant to be less painful than one in the back, but just to be clear, this isn't a little injection under the skin. There are people who might have had blood thinning treatment or diabetes treatments that are just under the skin. This is a deep injection, and it's both sides. There's 2 drugs in this combination, and it's 1 injection in each side. So that straight away isn't going to be for everybody. Now, they're looking at other ways to give it. So giving it into the thigh muscle, and you know, people do their own deep injections. Some people, you know, steroids, for example, and prescribed treatments. So it may be something more suitable to be given at home, but certainly for now, it's going to be the clinic delivering it into a deep muscle.
Of course, every 2 months. That means, I mean, the attractive side of that from a service user's point of view is that 6 clinic visits a year. That's obviously more trips to the clinic than we're doing at the moment, but it's so many fewer instances where you need to be reminded that you have HIV if that's a problem for you, or just remember if you have problems, remembering to take your tablets on schedule, then you don't have that to worry about.
Absolutely. So for some people, this will be a game changer. And it's important to mention you need to have an undetectable viral load. These drugs haven't been studied for people who've got detectable viral loads. Only people are already undetectable on tablets. And you can't have any resistance to the components. So one of them in particular, these 2 drugs, it's a little bit, we call it fragile. It's a bit wimpy, for want of a better word, compared to some of the stronger drugs. And if you've got any history of resistance to that particular drug, it's not going to work. So it's straight away, there'll be some people who it won't be suitable for you because you've got resistance, or because you don't have an undetectable viral load. Now, that doesn't mean we'll never use it in people. Let's say we've got someone with a detectable viral load who there's no other choice. It's going to be this or no treatment. Then, of course, we'll have a careful discussion. The guidelines might say we shouldn't use it if you've got a detectable viral load, but guidelines are guidelines. We can always deviate from them if we need to. But in general, this is where it's difficult. The ideal group of people are people who are really struggling with tablets. But to find people really struggling with tablets who are also undetectable with no resistance, it can be a tricky balance. So I think it's going to be a slow burner, I think is the likelihood. And of course, coming to
I was just saying the injection, the timing is really, really critical as well. So as we all know that on the odd occasion, if you happen to miss a dose of your tablets for one day, it's not necessarily the end of the world. But if you deviate from your allotted injection time by as much as a week, that can cause problems, can't it?
Absolutely. So you've got to have these injections within 7 days. So let's say your injection is due on the 7th of March. You can have it between the 1st of March and the 14th of March. And in the trials, they were really good at keeping people. People in clinical trials are chosen carefully for a good reason. Drug companies want the drugs to work, of course. They want them to be safe, but they want them to work. And so this is a difficulty, is can we achieve the same great injection schedule adherence in real life that they did in the trials? And this is the thing, so the monthly versus 2 monthly thing, if I said to everyone, would you rather come in 12 times a year or 6 times a year, to me that's a no-brainer question. Would you prefer monthly or 2 monthly? I think, of course, unless you're particularly enamored with our bamboo wallpaper, I would suggest most of you are going to choose every 2 months. But let me tell you this. So if you get the injection every month, on time, never miss a dose, after a year, there's a 1 in 100 chance your viral load will come up, even though you've had the injections on time. 1 in 100. Now that's up to year 1. After that, there's no additional people who get the viral load rebound. So if you're on the monthly dosing, 1% chance at a year, and then the viral load seems to stay undetectable. Again, this is in the context of always having your injections on time. Every 2 months, 1 year, it was 1 in 70 people. So they had their injections every 2 months, but 1 in 70 chance of the viral load coming up. After 2 years, it was 1 in 60. After 3 years, it's 1 in 40. So that's a 1 in 40 chance that your viral load will rebound even though you're having your injections on time. Now, for some of you, that's an acceptable risk to take. Absolutely. But it's important that people understand that, because by and large, with tablets, if you take them every day and you don't take drugs that you're not allowed to, so some of the drugs you can't take with indigestion treatments or whichever, we're pretty confident that your viral load will stay undetectable. But to say to you that even if you have your injections on time, and give you an example, so the 2 new cases in this particular trial where the viral load came up was presented at a conference last month, and the viral loads weren't low, they were sort of in the tens of thousands. One was 14,000, one was 25,000. And if you've got HIV negative partners, then the whole U equals U thing, it's difficult. And I think if a detectable viral load would be a disaster, then you need to seriously think about whether this right now is the right option for you. And again, I'm not trying to put anybody off having it, but I want people to be aware that this is an issue, and I'm slightly anxious about what we're going to see in real life, because these were in the clinical trials.
What does that mean in real terms, though? Why are these people who are getting the required amount of the dosages experiencing virological rebound? The studies that I've read, or the abstracts that I've read, have all seemed to suggest that there may be an underlying cause, like some residual resistance to rilpivirine, but surely that would have been assessed prior to people starting.
No, good question. So the difficulty is that not everybody's got a baseline resistance test available. And if they do, the resistance that we report on our test results has evolved over time. So some people have a resistance test when rilpivirine, for example, one of these drugs, was a twinkle in a pharmaceutical company's eye. It didn't exist. So we weren't reporting resistance. We didn't know what rilpivirine resistance was back then. So what we can do is do a resistance test on the DNA. So if your viral load's undetectable, we can't do a resistance test just on the virus in the blood because it's undetectable. But what we can do is get the virus that's hiding in your cells and do a resistance test on that. Now, that's not a test that's done routinely. It's not routinely recommended before you use these drugs that you necessarily have to have it. So we're learning. That's one of the reasons. But for me, I think the issue, Nathan, is that it's by stretching that dosing to every 2 months. Every month means everyone's getting enough drug. If you're stretching it, it's just pushing it a bit too far for some people. Because if you take a group of people and give them the same dose of drug, some will have nice high levels, some will have too high levels and they'll get side effects. Others, it would just be on the cusp. And for me, it's stretching it a little bit too far. I mean, I've been famously slightly pessimistic about this 2-monthly dosing from the beginning. I really want it to work, but I don't want us to create more harm in the future, because the thing is, not only is the viral load quite high, you end up with resistance almost always to both of those drugs. So that may mean ending up on a drug that really isn't ideal for you because the resistance has developed. So I think we do need to be cautious. And again, if you really want injectables, you can have injectables as long as you don't have existing resistance, then we won't give it to you. But these are just things to think about. And that balance of what's an acceptable risk is going to be very individual to you.
But at the moment, it's only cabotegravir and rilpivirine that are being delivered in this way. Do you anticipate that will be followed soon by some of the other drugs that we might already be on? Because no one's going to be on.
Yeah. And that, it's almost like, and Nathan hasn't even seen my slides. Nathan, that's a perfect question, because it's a journey, right? And this is the very first long-acting treatment. And what we'll move towards is muscular drugs given less often, subcutaneous drugs given under the skin, which you can do at home, tablets that you can take just once a month, implants that you put under your skin, skin patches. At the moment, there's only one drug that would even feasibly be available in a skin patch, and it would be pretty massive. But all of this is in development. So I think for people who absolutely need this now, we will get it to you now. For people where it's a I would like rather than an I need, I personally would encourage you to wait, because I think what's tricky is some of these future options won't be an option for you if we've blown it early on. And that, as I've said, won't be your fault by any stretch, because you'll have had your injections on time. So I don't want to be scaremongering, but I also want to be realistic that these first generation is not perfect.
I think from my point of view as a service user as well, and I know that you wouldn't be able to say this, so I will, because I can get away with it. This is going to put a big burden of resources onto the clinics and the clinicians. Yeah. And obviously you will all be bending over backwards to be able to provide that service to whoever needs it. But from my point of view, as someone who tries to be a responsible service user, I don't need that treatment. Yes, it would be lovely to come in once every 2 months, but I would be putting an unnecessary burden onto you. And I think that needs to be assessed on an individual level by the individual service user, I suggest.
Yeah, absolutely. And I think it's an okay thing to say, and certainly we've said that. So the British HIV Association draft that's on the website, and again we've done a kind of sort of a non-technical summary of that as well, which is freely accessible on the website. And we do say that you know that the resources will be limited and people need to be prioritised, and those are people already on injectables because they took part in the trials, people who are just cannot manage tablets right now. So it is a conversation, and although it's approved nationally, so the NHS is obliged to provide it, it's not obliged to provide it to everybody. That's in the context of each individual case assessment. So, you know, again, if you really need it, you'll get it. If you would like it, then we will probably have an honest discussion with you about what's realistic.
Great. That's fascinating. It really is. I think it's one of the most exciting times to be aware of what's happening in the field of HIV research at the moment.
No,
you've been part of the HIV world for 20 years. That's half of the duration of the problem that we've experienced with HIV in the Western world, and I think that's what you must have seen, the changes from then to now. Surely for you, sometimes it must be hard to keep up.
It is. It's been remarkable. I mean, I'm not, you know, I'm what I call a post-heart baby. So heart's a term we used to use for highly active antiretroviral therapy. So mid-1990s combination therapy, and that's when things really started transforming. Some of the drugs were pretty horrible, but it meant for the first time people were getting undetectable, staying undetectable. I've only worked in HIV in the era of effective treatment, so I've seen the legacy of it, and as a medical student, I spent some time on the wards and saw some of it. But even though I've always worked in actually a relatively luxurious period of HIV treatment, this is still a remarkable achievement. And when I spoke at our national conference in last year, I gave a very honest summary of the data, but I also made everyone give the drug company a round of applause for developing this, because it is hugely important to people living with HIV, and I think it's a great development, but it is just the first step on a journey towards much, much, much easier to take options.
Can you just, before we move on from this subject completely, can you just give a little bit of an insight into using the same injectables as PrEP? Because I know there's going to be people who are not living with HIV who may be interested in what that can provide for them.
Yeah, so the two drugs we give, injectable rilpivirine and injectable cabotegravir. So rilpivirine is a drug we use in tablets. Cabotegravir is a lot like dolutegravir, a drug we use a lot, and the one I mentioned earlier. They were both being looked at for prevention, but for various reasons, rilpivirine didn't quite cut it, so that was stopped. It's only being used for treatment. But cabotegravir is also being looked at as PrEP, pre-exposure prophylaxis, giving it to people at risk of HIV who are HIV negative, and it's very effective. And it's more effective than tablets. At the moment, we give the old brand name Truvada. We, of course, give the cheaper generic version these days. But instead of taking a tablet every day, people have an injection every month. Or I think there's some 2-month studies now. And it's more effective, but it's only more effective because people don't always take the pills. And if you look at people who take the pills every day, the tablet is still just as effective as the injection. And with the injection, although a very, very small number of people get HIV despite the injection, if they do, there's a reasonable chance of resistance. So this is where we keep doing this in HIV. We use the same drugs for prevention as we do for treatment. So I think we need to think really carefully about, should we be using drugs for prevention that there's a risk of driving more resistance to the drugs we need for treatment. And again, it's a tricky balance, because if hardly anyone's getting HIV on PrEP, it's only a tiny number of people, but they do work well. They will be available at some point. And again, how the NHS prioritises those and rolls them out for prevention is a little way in the future.
One day soon, hopefully, it'll all be a home kit with an EpiPen, and we can all take care of our own treatment that way.
Exactly. So I've literally got two slides from my closing thoughts. So the first thing is, the future of the service. We've got a clean slate. The most important thing we do is we need to look at our own data from our groups, from our surveys, from your views, and we're going to listen to what you want the service to look like, within reasonable limitations, of course. With an unlimited budget, we'd be doing even more than we do now, but we will listen and make sure the service is the best one that we can offer you. And then the other thing is, and I'm not going to talk about this anymore today, but we're about to go through the biggest period of NHS reform for the last decade. And integrated care systems are these regional groups that in theory will bring together GPs, specialists, social care, all sorts of things. We're in North Central London, and how our HIV service, which is part of North Central London, along with the North Middlesex and Royal Free HIV services, how we fit into these new structures, considering that depending on how we define our boundaries, only 30 to 40% of people coming to our clinic live in North Central London. That's going to be a real challenge. And as we learn more about this, I will come back and talk about it again, or someone else can come back and talk about it. Because how your voice is heard as a North Central London patient, but not a North Central London resident, if that applies to you, is something we need to think very carefully about. But I don't want to dwell on, there's so many uncertainties, I don't want to dwell on that any further now. So
may be required to change the clinic where they get care if they're not within a given catchment area.
So we have, at every single meeting, made sure, I've had it verbally from very senior people in the NHS, that people with HIV will continue to be allowed to get their care wherever they want. I have failed to get anyone to put that in writing. I had a meeting with Professor Kevin Fenton, who's very, very famous in the fields of public health and stuff, this week, and I've asked him again that we want to see that in writing. The reality is, over the next 5 to 10 years, I think it's going to be increasingly difficult to get all of the care that you need outside of your own residential area. And that's not that we wouldn't see you in the HIV clinic, it's that, are you going to get the best referral pathways to mental health care, to social care support, and all those kind of things if these regional structures aren't where you're living? Now, again, I don't envisage any time when you will be forced to get your HIV care anywhere other than where you want to, but you may find as you age, as you experience more things, as your care does get more joined up with other elements of the NHS and social care services, that naturally for you, actually, interestingly, one of the things that happened during COVID is people who are traveling very long distances to come to our clinic were forced to experience care more locally, and they've stayed with their local services because whatever fears they had or whatever negative experiences they had 15 years ago, things had changed. So our clinic has shrunk by a few hundred people. Some of that's thanks to bloody Brexit as well, and people, you know, who have chosen not to live in the UK any longer. But some of it is people who during COVID realised that things weren't perhaps as bad as they'd experienced or feared.
Great. I've got some more questions for you, one of which is very quick, and I could actually answer it myself. It was somebody who's asking, what is the injectable drug called? The combination is Cabenuva, and that's the part of our cabotegravir and rilpivirine, and I am now adding that to the chat so people can see those words, because sometimes the names of these drugs, they rattle past, and as I can see it, I don't really understand what I've just heard. So that's that one. But there are two questions for you, Laura. Is there any focus on HIV and diabetes with each other? And is this something that the clinic is going to be focusing on in the future, especially with such a high percentage of people with HIV later developing diabetes, according to research? Is that something that there is specific reach for that?
So the reality is HIV probably isn't a particular risk factor for diabetes. And the studies that show whether HIV drugs contribute to diabetes, actually, they probably don't. There's maybe an old drug that even in a cost-constrained NHS we never use anymore, called stavudine or D4T, which may have been, or didanosine or Videx or DDI could cause some damage to your pancreas, which is where insulin is made, and that could cause diabetes in some cases. So the reality is diabetes is incredibly common in everybody, and as you know, HIV is increasingly well controlled, that opens people with HIV up, thankfully, to not HIV specific conditions, but all of the conditions that are, you know, a heavier and less healthy population, because that is the direction of travel. We live in an obesogenic society, and it's weight primarily that's driving diabetes. So it is certainly something, you know, continuing. There's lots of research ongoing, but as a common condition that people with HIV experience, then yes, we will be looking at some more specific guidance. And locally, there's still some tweaks, but we have pretty 95% got agreement to fund a dietitian, because we used to have a dietitian in the service, then we didn't, and actually a dietitian would be a really important part of managing the mainly lifestyle risk factors that drive things like diabetes. So we will be looking at some specifics. We have already got some relationships built up with the diabetes service at UCH next door. So the answer is yes, but I do want to emphasize that the contribution of HIV and HIV drugs is, if anything, very small.
Thank you. Just before I ask our final question, if anybody else has any questions, we've got 14 minutes left. If anyone else wants to put any more questions to Laura, please do put them in the Q&A. And again, you can always tick that anonymous question box if you want us not to know who the question is coming from. That's absolutely fine. So please do that before we wrap up. But the last question there at the moment is something I was going to ask you as well. You mentioned earlier that you want sort of focus groups and you want input from us. How can we do that? Where can we sign up? Where can we watch for information about that? Is it just a case of waiting for text messages come through? Is there can we email a certain person to say, I would like to be involved in the future of the clinic's work?
So there is, well, one of the staff focus groups is a focus group focusing on patient engagement. So really that's down to them. I've kind of taken a back seat as somebody who, particularly during COVID, made a lot of decisions going in. We're trying to involve everyone but me coming out. So I'm not the best person to answer that question. But Stuart Flanagan, who I'm sure many of you will have met, one of our consultants, is leading on that group with of course input from the peer support workers. So the answer is we'll be in touch. We'll be asking the network to absolutely help us organise that and facilitate it. And we will likely there's a limit to how often we want to keep sending people unsolicited SMS messages, but you know, in conjunction with you guys, we will likely use that as a route as well to encourage people in. So you will hear more.
Great. And if anyone has any particular questions that they want to put, you can use the Bloomsbury Network as a sort of conduit for that. If you want to email admin@bloomsburynetwork.co.uk, so we will be able to field those inquiries and direct them to the right people within the clinic if it's not something we can answer ourselves. So you can always get in touch. One of the things I always say about the Bloomsbury Network is it's not our network, it's our network, and it's really important that we on the committee are not just this little cliquey group of people who feel what we decide is right. We can only get it right if we're speaking on behalf of the wider patient group as a main cohort. So it's really important for us. So let us be your network, because it's your voice that counts. One question is here for you, Laura. Is there any chance that HIV can cause problems in the mouth and with teeth? And was there ever an MMC dentist?
I mean, I've not been there long enough. Certainly at Chelsea Westminster, we used to have a dentist in the clinic, but that was really in the era of very advanced HIV and lack of effective treatments, and you know, and conditions of the mouth can still be the first sign of HIV. So there's some particular things that are associated with HIV associated immune damage. But by and large, no, well-controlled HIV isn't associated with any greater risk of mouth or teeth problems. We don't have a dentist, and unless new evidence emerges, we won't be getting one. Unfortunately, you are subject to the same hassles of finding dental care as everybody else, unfortunately.
And one final question before we wrap up: what are the clinic doing to help engage people with disabilities? Is there anything that this is something that will be focused on in the future? Working with the deaf.
Sure. No. Another good point and good question. So, I mean, we already have access to British Sign Language translators, and of course translators for anybody for whom spoken English isn't their first language. And again, that's going to be part of the broader patient engagement work. Is about what can we do. Because again, I think that's where we need your help, because people affected by that may not be the people who are coming forwards, they may not be the people answering the surveys, and they may not be the people attending the meeting today. So I think your guidance is going to be crucial there, about telling us how do we best ensure that any barriers to care are overcome, whatever the reason is.
Would you, I mean, I would probably imagine that if anybody is dealing with a disability in their daily lives and they're feeling that the clinic is falling short in any way on whatever level, the best thing to do is to get in touch. Because if there is something we're not aware of that we can do better, either with the network or you, the clinic, every effort will be made to resolve that as a problem.
No, that's absolutely the case. And so one of the things that we did, and I don't know where to pop it in the chat, Nathan, perhaps you can. So we've got a newish, it's been going for several months now, an email account. So again, if you go onto the website, there's one single number. I admit choosing option 1, 2, 3, 4, 5 and 6 is a bit of a pain in the buttocks. Not as painful as those injections, by the way, but it will be a bit painful. But at least it's a single point of call for pharmacy, peer support workers, health advisors, etc. There's also an email address, b.patients@nhs.net, and that is checked every single working day at the moment by one of the consultants. So you're getting rapid access to somebody pretty, brilliant, thank you, and Nathan as well, double whammy. So some mornings that will be me. If you're lucky, it'll be Altig or one of the others. But that is, and eventually at some point, that some of that will be handed over to other members of the team, but right now it's still a consultant checking that every working day. So that is an entirely acceptable route for you to contact us for pretty much anything. If there's a better way to get that advice, we will let you know. But you know, people running out of meds, questions about vaccines, concerns about anything housing letter type stuff, we can either address it or direct it to the person who can deal with that for you. So please do use that to get in touch.
This is brilliant. I mean, I personally, I feel very well looked after. I'm aware that I'm not in one of the harder to reach categories within your patient cohort, but I do feel that the level of care that I get is second to none. And the reason why I was asking about the catchment area is because I probably live outside it and I do not want to go anywhere else.
But please, no, that is definitely not on the cards.
Fabulous. The other thing that I wanted to say just before we go is I know COVID put the kibosh on many of the research programs, and I know Mortimer Market Centre is part of one of the largest HIV research clinics in the world, isn't it, doing the cutting edge forefront stuff. How is that recovering, and who do you need? Can we do a quick recruitment drive for anybody?
Well, I mean, the main study that I think one of the real missed opportunities with face-to-face appointments is promoting trials, because as you're sat there, because someone like me is running a few minutes late, there's posters promoting things, there's various ways to find out about trials, and I'm not sure we've done that's one of the things we've really not been very good at with our telephone consultations. So there's an ongoing discussion about actually getting a page on our clinic website with currently recruiting trials. It's always a bit tricky because with a trial, you need ethical approval for, you know, is it okay to give this treatment? Is it okay to do these tests? But things like sort of promoting trials directly to people who might be eligible also requires ethical approval. So it's not quite as straightforward as it might be. But there is that route. But things are recovering. What's difficult is when trials are different to real care. So trials, you often have to come in every 3 months. And there was a time when everyone had to come in every 3 months for HIV care and HIV monitoring. And as HIV care and monitoring gets simpler and simpler, it becomes more and more of an altruistic endeavour to necessarily take part in trials. But they are there. We need to do a better job of promoting them. It is recovering. The thing is, a lot of, it wasn't just that COVID interrupted HIV research. A lot of HIV researchers and research clinics shifted towards COVID research. So it's going to take time for things to pick up again. But again, I think that's part of what you can help us with in the part of the sort of focus group work. How do people want to hear about trials? You know, we don't want to bombard people with information who aren't interested. We've long talked about having some sort of system on the electronic record, because at the moment the research team will go to individual doctors and specialist nurses and say, is it okay if I contact Nathan about a trial? It's not my decision, Nathan, it's your decision. So if I'd said to you, when you first registered, are you happy for the trials team to contact you if you're eligible for study? And you said yes, then that could happen automatically. So various things that we can do to make it better. But again, it's going to be a work in progress.
Thank you so much. As always, it's been fascinating to talk to you and to sort of have a window into the other side of clinic life, because I know what I experience as a service user and as a patient there, and a little bit on the inside because I know people through my work with the network. But it's really lovely to see what it's like from your side. It must have been incredibly difficult over the last 2 years, and as I say, I think the work has, even where you may not have always got it right, the endeavour was there, and that's the thing that matters to me personally. But thank you so much for your time today, and I really appreciate it.
Always an honour. She'll bid you all farewell. Thank you so much, and look forward to coming back at some point in the future when you'll have me.
I will have you anytime you like. So just before we wrap up, I've got 4 minutes to very quickly say to everybody, please do, thank you, Laura, please do get in touch with the network. If you aren't a member and you would like to be, you can go to our website and you can sign up there, or you can email admin@bloomsburynetwork.co.uk. Also, if you want any information about the Beyond Diagnosis course I was talking about earlier, that's one thing. But and we're very, very happy to take any inquiries or answer any questions you might have about that. So please put those to us as well. But I was talking about the research study programs for a very good reason. Our next forum event, our next webinar forum is going to be with Ms. Tamsin Cumming, who is a colorectal consultant at the Homerton Hospital. And she is going to be talking to us about, in May, thank you, yes, that's in May. So we haven't got one in April, thank you, Geoffrey, reminding me. That's going to be in May. Date to, have we got the exact date, Geoffrey, or is that?
That'll be out shortly in the next newsletter.
So we'll have the date of that. And Tamsin's going to be talking about the CPAC study. I can't remember exactly what it stands for, but it's to do with a screening program looking for the prevalence of anal cancers within mostly men who have sex with men and trans women who have sex with men who are living with HIV. And it's a really, really important study because we all know that with cervical cancer, there's routine screening programs for women for that, and the incidences of deaths from cervical cancer have reduced by about 80 to 90% since those screening programs came into place. But there's no equivalent screening program for anal cancers in men and trans women who have sex with men, particularly living with HIV, because there's a high risk factor attached to that. So if you want information about that, Tamsin's going to be talking about that. I've taken part in the study, and guess what? Spoiler alert, they found a little something and I've had some treatment. So I absolutely would recommend anybody who wants to give their time, but with the benefit of perhaps of finding out something very important to their own health and well-being, to come along to that forum and then maybe sign up for the CPAC study. None of it hurts. None of it was particularly dignified, but I think we all need to start talking about these things in a much more normal way and getting rid of all the demons we have about talking about our downstairs. So these things matter, and health is far more important than any kind of stigma or embarrassment. She's a doctor, she's seen it all before.
And just to add to it quietly, I've been part of the trial as well.
Thank you, Geoffrey. So we can say we're still sitting here and we're still quite happy to talk about it. So that's coming up in May. Thank you to everybody tonight for taking part. This has been really fascinating. It's always a pleasure to be able to deliver these kind of forums on behalf of the network with fantastic guests like Laura, who is endlessly fascinating and wonderful. And we're so proud to have her as our clinic lead. We're proud to represent you, but we, as I said earlier, we can't represent you without your input. Thank you so much for participating tonight. Thank you for being part of this. We will see you on the next one. I'm going to end the webinar now. Please do fill in that survey. There's only 11 questions on it. It won't take long. Thank you. Good night.
Right.